Thank you everyone for joining us today. We will begin shortly. Welcome everyone to today's webinar. I am Aaliyah Pavla with Becker's Healthcare. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Q&A and clicking send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Peter J. Mallow is an advisor to Cardinal Health on health economics, policy, and reimbursement matters. He is the Director of Health Economics and Clinical Outcomes Research and Assistant Professor at Xavier University in Cincinnati, Ohio. His research interests include economic evaluation and decision-making within healthcare systems. Now, to lead our discussion on new trends and strategies for ASCs, I'll turn it over to Dr. Mallow.
Thank you, Aaliyah, and thank you, Beckers, for having me today. Most importantly, thank everyone listening in for your time. I appreciate it greatly, and I hope through the course of our hour that you find a few things to take away and improve your practice in your ASC. I want to take a moment to introduce myself with one more important disclosure, and that is I have a total knee replacement scheduled at the end of this month, and I'm heavily invested in the ASC market because after careful consideration, I chose to have that total knee replacement in an ASC. And we'll talk a little bit of why in a few minutes. With that said, though, let me just cover the agenda quickly, and then we'll get started after a brief comment from our sponsor. At the end of our session today, I want to make sure you understand the role of the ASC in our current value-based environment, talk and understand and be able to describe the major challenges or headwinds, if you will, and opportunities or tailwinds, if you will, facing the ASC market over the next 3 to 5 years. And finally, I want to leave you with a few strategies that may be able to position your ASC to take advantage of those tailwinds and avoid those headwinds. So a quick moment from our session sponsor, Cardinal Health. Cardinal Health, many of you know as a leading logistics company throughout the entire United States, but they're much more than that. They're a manufacturer of numerous medical supplies, devices, and pharmaceutical products. And for those of you that have had the Cardinal Health truck show up in the recent past or near future for that matter, I'm sure they thank you very much for your time. They also bring together business-centered and patient-centered solutions that you might not be aware of and may ask about next time you speak to them that seamlessly connect your business and your patients to enhance the coordination of care and improve their health. Cardinal Health is uniquely able to provide you with what you want most, a simple way to support your reputation and deliver quality care while lowering costs. With that aside, let's get into our session today and talk about that current landscape. Many of you are aware that our system is complex, and it is growing in complexity every day that we speak. And I just want to highlight a few themes that are pertinent to the ASC market. First is this concept of healthcare consumerism, the idea that if the patient or the individual has skin in the game and pays for a substantial portion of their healthcare out of their own pocket, they'll make better decisions. The second is the government's ever-expanding role. It seems that every month there is a new rule coming out of CMS or the FDA or some other part of the government that's requiring you to do more administrative work to comply with it. That's not going to change. Also, the shift to care to more efficient settings. You are the primary beneficiary of this in the ASC market, as procedures have moved from the inpatient hospital setting to the outpatient department to the ASC and even beyond, and that is moving ever faster as we search to provide lower cost care without suffering any decline in outcomes to the patient, which leads us to this concept of value-based care that we're in the middle of. It's the triple aim, if you will, where we can improve outcomes, improve the patient experience, and lower the cost of care that we're trying to reach every day to bend that cost curve, as we hear so much about in the media. So let's get into that in a little more detail. Since 2005, we've seen a huge shift in procedures from that inpatient setting to the outpatient. In 2005, only 42% of all surgical procedures were performed in the inpatient setting, leaving about the other 58%, if you're doing the math with me quickly, in that outpatient setting. And that has continued to decline despite the population increasing. Next year, we expect only 36% of procedures to be performed in the hospital inpatient setting. Where are they going? Let's take a look at the bottom on the slide, and we can see that the ASC has grown tremendously from 41% of outpatient procedures in 2005 to nearly 60% today in the outpatient setting, roughly a 46% increase over the last 15 years. That has caused quite a bit of competition in the ASC market, especially in the major markets, as we have seen the number of licensed Medicare ASC facilities increase from roughly 3,000 in the year 2000 to over 5,500 in 2016. When you include non-licensed Medicare facilities and take a look at some of the most recent reports, we see roughly 6,100 total ASCs in the United States, over an 82% increase. The good news is procedure volume is expected to increase 14 to 16% per year through 2026. While the competition has been increasing, your costs have been increasing as well. And I want to take a moment to expand on that because it's very interesting. Many of you have supplies sitting in your closet or on your shelves that you know have been manufactured the same way, distributed the same way, consumed or used in the same way for the last 20 years, much like a gallon of milk. And if we go back to that year 2000, we look at the price of a gallon of milk from the Bureau of Labor Statistics, it was $2.79. Fast forward to today, $2.85. The price effectively has not changed because that gallon of milk hasn't changed. When you factor in inflation, that dotted yellow line, we see that the real price of milk has actually declined over the last 20 years. But if we were to put that gallon of milk into the medical system and all the administration that comes with it to regulate that gallon of milk, we would see that it would cost $5.19 today. That's quite a bit of an increase for something that has not fundamentally changed in any way, shape, or form, much like many of your medical supplies and devices that are in your ASC today. At the same time, we've been targeting the costs of healthcare from the insurance side. And what has that resulted in? Payments are declining. Medicare, as well as the private insurance companies, have constantly been coming up with new ideas, whether it be not paying for healthcare acquired events, Medicaid dish, Medicare dish, hospital sequesters, coding adjustments, productivity adjustments, value-based purchasing, and I can go on with the different programs that they have introduced just in the last 10 years alone. The result, though, is an expected $500 billion cumulative decline in payments to you, the healthcare provider, expected through 2023. The ASC market is uniquely positioned, or you can say negatively positioned in this space, when we look at performing the same procedure in a hospital outpatient versus the hospital or versus the ambulatory surgical center. Take that partial knee arthroplasty that you see. I wish I was having one of those. For some reason, maybe I can deal with that in the question if somebody asks, but I have to have the total knee. And the cost wasn't my driving factor. We'll get to that in a minute as well. But we see that in the hospital outpatient department, a partial knee arthroplasty costs $10,600 versus $7,300 in the ASC, roughly a 31% decline. When we take a look at lumbar spine fusions, pacemaker implants, we see that it's a nearly 52% decline from the hospital outpatient to the ASC. The idea when the ASCs first became prevalent was that they would be a more efficient site of care and therefore not have the same cost structure as the hospital outpatient department. And that's why we have the differential in reimbursement to begin with. But due to inflation and due to other factors and rulemaking from the insurance companies, that has only increased, or that delta or difference between the hospital outpatient department and ASC has only increased over the last several years. The good news is some of the regulatory changes for 2019 are addressing just that differential. And let me take a couple minutes to highlight those policy and regulation changes for 2019. The first is a site payment neutral rule, or a better way to put it, as the screen says, site neutral payment rule. And as we look into that and think about that, what has gone on over the last several years is healthcare systems have bought standalone ASCs and turned them into hospital outpatient departments to collect that increased reimbursement that we saw on the prior slide. The government has said no longer to that and will be putting an end to that practice in 2019 and going forward. Also, over the next 5 years, we expect through changes in how we calculate inflation to increase the reimbursement of the ASC procedures. Basically, what had happened in the past has been that CMS has rewarded hospital outpatient departments with a higher inflation adjustment than they were with the ASCs, and that's coming to an end. There's been several new procedures introduced as payable to the ASC. Those are in the cardiovascular, diagnostic, and imaging space. All said and told, that's 17 new procedures that will be reimbursed in the ASC market going forward. New device threshold limits have been put in place that will benefit and help adjust payments for the ASC space. And what this is that procedures that are heavy on devices will now be compensated more. And what exactly does that mean? The device threshold used to be at 40%, it has been reduced to 30%. So if the cost of the device is more than 30% of the procedure, according to CMS, it classifies itself in a new category for increased reimbursement. And finally, it's not a big win, but the government has recognized in our current administration that we need to reduce the rules and regulations and administrative burden that we place on our healthcare providers. And they've eliminated 4 ASC quality reporting requirements for 2019. These deal with patient burns, patient falls, hospital transfers, and things that are relatively minor and not occurring frequently within that ASC space. So with the lay of the land, let's start thinking a little bit about those headwinds and tailwinds facing the ASC space today. Our healthcare systems are going to continue to vertically integrate and continue to expand through acquisitions or through ground-up build-outs of their own ASCs. Despite the change in the site payment neutral compensation scheme, they are moving forward with acquisitions such as Tenet Health acquiring United Surgical, Envision Healthcare acquiring AmSurg, or even Optum acquiring surgical care affiliates. These well-capitalized organizations are using their clout to take over the market to the extent that they can so that they can retain all of the patients in their healthcare system, from the primary care practice to the specialist to the ambulatory surgical center if needed, and certainly the hospital at that top of the pyramid. And they're going to continue to do this, and the reason why, our insurance companies are doing the same thing. They are merging with each other on a regular basis, and they're using their combined members now to turn around and negotiate with you, the provider, lower reimbursement rates. Centene and WellCare are in the news right now for their proposed merger. Just out today, in the last couple of days though, I've seen some rumblings regarding whether or not this merger will conclude, but that said, we can expect other insurance companies to be merging, whether it be Cambia Health Solutions and Blue Cross Blue Shield, or perhaps others in your particular markets. The name of the game is having more membered lives allows them to negotiate lower reimbursements and control the market in the places that they operate. What does that mean to the consumer? Well, we've talked about healthcare consumerism, and that is high deductible insurance plans. Over 40% of all private insurance members under the age of 65 are enrolled in a high deductible plan. I'm one of them, and I can tell you that my own personal deductible is $3,500 for that upcoming knee replacement, whereas the average is $1,350 for an individual or $2,700 for families. When you combine that high deductible amount plus the premiums coming out of their paycheck, the typical family in the United States is paying nearly 15% of their gross pay in healthcare should they use that whole deductible in the year. That's causing quite a bit of strain on their household finances when you factor in housing payments, transportation, food, clothing, and entertainment. In a recent poll from the National Health Interview, 56% of insured adults reported difficulty affording deductibles, and Kaiser Health, in their recent poll, reported nearly 30% can't pay those medical bills. What does that mean to you, the provider? I'm sure you're seeing higher unpaid bills, perhaps turning more money over to a collector, such as Quest Diagnostics, who recently reported an $80 million loss due to unpaid bills related to the high deductible plans. This is causing people to shop or delay care while they shop for their procedure. It's also causing people to forgo healthcare altogether and perhaps, in a worst case scenario, be admitted to the inpatient hospital with an emergent condition that could have been dealt with electively had they not been worried about their own household income and finances. On top of all of this, you're dealing with labor shortages. That's not going to change over the next 3 to 5 years. We expect a physician shortage due to the baby boomers and Generation X and Generation Y, or the millennials, to only increase through 2030. High estimates of that shortage indicate over 100,000 physicians needed, and we see similar reports, whether it be nursing practitioners, medical techs, medical assistants in coding and billing, as well as nursing. All of this is causing a significant wage increase for the clinical staff and the office staff, not so much for the physicians, for those of you that are a physician out there, and that's driven by your CPT codes and RVU-based payment system, but we're seeing that increase in pay, which is obviously pinching your practice and expected to continue for the foreseeable future. Finally, The last headwind I want to talk about before I turn around and think about some good news is that the same pressures that are putting procedures in the ASC today are causing to go down one more step further to the office. And we've seen the rise of the office-based lab or the office-based surgical suite over the last 4 or 5 years. In 2012, there was an estimate of 350. 2016, we expect over 600. And it's very difficult to find good numbers on this because the office-based labs do not have the same licensing and regulatory framework in which they need to operate in that you as the ASC provider do or the hospital does, which allows them to take further advantage of that reduced administrative burden to perform procedures, whether it be eye, dermatology, peripheral vascular, or dialysis, access, and maintenance procedures in these office-based labs. Each one, we expect to perform 900 cases a year, and you can see that they are in all major markets across the United States now. So some tailwinds and good news going on in this space. I mentioned Medicare site neutral payment. This will change the dynamics of hospitals looking to acquire an ASC in your market and create additional opportunities for you to perhaps partner with them. It will create additional opportunities for you to take advantage of the lesser administrative burden and requirements of the ASC compared to the hospital outpatient department. And with that, I want to highlight one important factor, and that is the steerage of patients to you in the ASC space that we're seeing from private payers increasing over the last couple years and expected to only increase further over the next several years. What the private payers have recognized is that you are a more efficient site of care, achieving that triple aim for them. And they're trying to steer patients to you through requiring pre-authorization restrictions for the hospital outpatient department that are much greater than yours. They're also finding ways to reduce the financial burden of that high deductible plan for patients that choose an ASC, whether it be a copay amount, whether it be pre-negotiated rates with you that can allow them to cover that payment at a lesser amount out of their deductible than they would otherwise have in the hospital outpatient department. And finally, what the private payers are doing in this space is this concept called reference pricing. And instead of comparing pricing within a site of care category, such as hospital outpatients in a market, they're comparing reference prices across the entire market for the same procedure, regardless of that site of care. And the idea being that we take a look and say in your market, there might be 3 hospital systems or 3 major hospitals and 4 or 5 ASCs. We'll average the price of that total knee replacement across all of them. And when we go to renegotiate our payment amounts to you or the hospital outpatient department, we expect to pay that average amount or less. That gives the ASC provider an opportunity to ask for more, whereas the hospital outpatient department is going to be asking to retain as much as they possibly can while they're being pushed down through reference pricing models. Now, the reason why I ultimately chose to go to an ASC, that is the outcomes. In my particular market, when I looked across the hospital systems that provide care, as well as the ASCs, I asked questions around infections, hospital admissions, 1-year revision rates, and when I totaled up all of that information, I found the ASC of my choice to have the lowest infection rate, lowest 1-year revision rate. After a year, I'm going to assume I did something wrong. So I'll get that 1-year warranty on the knee, hopefully. And what we look at, though, when we think about that is well, maybe it deals with the patient or the patient mix. And that is not the case. Research has shown that when we adjust for the patient mix and the patient severity, that the ASC continues to be equal or better in outcomes. Now, I'm just highlighting one component today, and that is the 7-day and 30-day hospital admission rates. We see here for all procedures across these categories that the 7-day admission rate for the ASC is about 50% less than the hospital outpatient department after adjusting for the patient mix. At 30 days, it's nearly 2/3 less. Let me put this in plain English. At 30 days, 1 out of every 100 patients in the ASC would be expected to have a hospital admission versus 3 in the hospital outpatient department. That's quite a difference. And through your hard work, it shows, and that's why the private insurance companies and even CMS are trying to steer patients into your site of care. Of course, I'd be remiss not to talk about our own demographics for a moment. That's going to be a significant factor driving the ASC market over the next 3 to 5 years as we continue to age and continue to deal with behavioral and socioeconomic factors that are linked to health, whether that be smoking, diet, or exercise. Nearly 40% of all Americans are clinically obese, and we expect over the next 5 years a 71% increase in the total joint arthroplasties, of which I'll be one of those. Nearly 30% of all Americans have heart disease, and we expect a 20% increase in cardiovascular diagnostic and intervention procedures. And that's despite or accounting for new guidelines, new evidence coming out around cardio intervention procedures that suggest in stable angina patients or non-STEMI patients that maybe we should work on medical management therapies first. So after accounting for that, we're still expecting a large increase in those patients undergoing cardiovascular procedures. With recent changes in what is payable to the ASC space, we're seeing these creep up and will be coming to fruition within that ASC space to have these cardiovascular diagnostic and interventions done on a routine basis in your site of care. And finally, we continue to adjust our evidence as new science comes out. And through those evidence-based guidelines, we've added 7% of adult Americans to the gastrointestinal screening pool. We expect, as a result of this change in practice, a nearly 20% increase in gastrointestinal diagnostic and intervention procedures over the next 5 years. So with the tailwinds and the headwinds facing your space, what are some strategies that you, as the ASC provider, can embrace going forward for the next 3 to 5 years to take advantage of those tailwinds and mitigate the challenges of those headwinds? The first one I want to talk to you about is control what you can, and that is your costs. A comprehensive digital supply chain management system is an absolute must in your ASC moving forward. The case study that you see here on this screen shows some tremendous benefits achieved through that comprehensive digitally based supply chain management system. Quite simply, it allows your clinical staff to do what they've been trained to do, which is patient care. It reduces the cost of your care, allows you to proactively manage your business, and it enhances ultimately that patient experience, the entire triple aim. And in this particular case study at one institution, we saw that it saved 3 hours in labor every day. It improved inventory turns through standardization of products by 60%, which allowed automation of the digital system and platform to proactively and automatically take care of expiration and recall alerts and eliminate 100% of expired product and recalled product on the shelves. And I want to highlight that last number for you for a moment. That comprehensive digital supply chain management system found $300,000 in chargeable product costs that were allowed to be reimbursed appropriately that was missing prior to the implementation of this system. So controlling what you can, much like the insurance companies control what they can, that's the payment to you, you can control your second biggest expense in the ASC, which is your medical devices and supplies, through this comprehensive digital supply chain management system. Once you've done that, I would suggest you take a look at all of your processes, look for ways to optimize them and improve them so that you can fully take advantage of that comprehensive digital supply chain management system. The first step would be informed shared decision-making on all of your medical devices with your clinical staff. You can use the information that you have now to sit down and standardize care pathways, so that way we can reduce the outlier cases to the extent that you possibly can. And through that, improve patient outcomes and drive additional business into your practice. And that can be done further by enhanced processes that strive for a no downtime minute for the patient. Digital records, digital histories, and physicals can be implemented if you haven't already done so now, so that the patient, when they walk in on the day of their procedure, doesn't have to fill out any paperwork and spends as few minutes as possible in the waiting room. Taking that same mentality to enhance each step of care throughout your ASC, so that way when the patient is ready to move from the waiting room to the pre-op room, it's done with no downtime, no waiting, same as the OR, same as the recovery room, and finally through discharge, where we can digitally manage all of our patient transitions within that ASC. And on that same concept of embracing the digital revolution for your practice, we've got to be able to communicate to those millennials and Generation Z folks who have grown up on a tablet or a smartphone or a PC, where that is their preferred way of communication for everything they do, whether it be scheduling, estimating their bills, paying their bills, and just as importantly, trying to find out which ASC to have their procedure performed at, and looking at various user boards on there. If you haven't embraced those digital platforms yet to reach your patient population, and I mean the Generation Zs and those millennials, because they are often the ones helping their parents make decisions that you see in your ASC today, you're going to be left out in the next 3 to 5 years. The last strategy I want to talk about today is how we can scale up without selling out. After you've controlled your costs and optimized your processes, what more can you do to take advantage of those tailwinds and mitigate those headwinds we've talked about? One option is partnering with an external management company. Many of you have started your ASC practice because you want to deliver phenomenal care, and that's what you focus on and do day in and day out. You did not start that practice to be an HR manager or an accountant, and the external management company can take those services off of your plate. Probably more importantly, though, is that they can leverage their own network in negotiating with private insurance companies for higher reimbursement across a number of ASCs in several markets, if the insurance company is common. And then they can turn around and negotiate lower costs for your medical supplies and devices through the same mechanisms of using scale. With the change by Medicare in site payments to hospital outpatient departments and ASCs to make them more neutral and prevent the conversion of an ASC to a hospital outpatient department, it opens up opportunities for partnership for that healthcare system in your market, where you can retain control, management of your ASC, but allow the influx of patients from that healthcare system into your practice. And we've seen from a recent advisory board report that generally speaking, these health partnerships are very beneficial from a revenue perspective after they've been concluded. One more thought for you is through your comprehensive digital supply chain management solution, controlling your costs, your optimized processes and scheduling efficiencies of your patients. You may open up an afternoon or a morning to attract another specialist into your practice who may not be part of your partnership group formally, but willing and able to take advantage of the ASC as a higher quality, more efficient site of care to perform procedures for their patients. This will give you the facility fee, and the specialist that you attracted would still retain their physician fee. So I want to thank you all very much for your time today. I appreciate it very much, and I hope you embrace the winds of change and have smooth sailing through some of the ideas we've talked about today.
Thank you, Dr. Malo, for sharing your insights on new trends and strategies for ASCs. Please remember to take a moment to complete the survey that will pop up as you close today's webinar. Your feedback is invaluable in helping us continually improve the value you receive from discussions such as this one. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Q&A and clicking send. We will try to get through as many questions as we can. There are a bunch of great questions coming through, so let's get started. The first audience member wants to know, given the quality measures that CMS no longer requires ASCs to collect a report on, which is ASC 1, 2, 3, and 4, do you see any value in continuing to track these internally? And also, is there a way to leverage this data to better position my center?
Let me turn around with a question back, and that is what outcomes do you want to improve by collecting this data? I encourage you to collect data only when you have an end goal or an outcome that's going to be improved for your patients. Now, obviously, when the government says you shall collect, you need to follow suit. But when you have that option for collecting data, even in cases where it might seem easy just to continue doing it, there's no reason of spending that energy unless you know exactly how you're going to use the data to improve your patient outcomes. For instance, ASC 4 deals with hospital transfers and admissions. That might be a great one to continue collecting for your practice despite it not being required, so you can turn around and leverage it to improve patient care. And assuming that you're continuing to do the awesome job that I know you are, communicate that broadly to the market as a marketing strategy, using that same data twice.
Great, thank you. Those are awesome points to consider. The next question is, commercial payers continue to consolidate. Does that make it more or less enticing to partner with payers as part of their preferred networks, recognized site programs, etc.?
Wow, a great question. I'm going to say locality matters. That depends upon the market that you're in. As the consolidation continues to increase, we see many major markets with only 2 or 3 insurance companies and several with only 1. And in that case, where there's only 1 major insurance company already in the market, I would encourage you to think about those preferred networks, recognized site programs, as that's a way to drive business into your practice without having to go to the healthcare system in your market. It gets a little trickier when we have 2 or 3 insurance companies in your market, because now the question becomes which one's the largest, which one can benefit you the most, as if you enter into that preferred network or recognized site program, you may be alienating the other insurance providers. If your market is highly fragmented, in my opinion, I would say discuss. It's always worth entertaining the conversation with the insurance company to maintain a good relationship when it comes time to negotiate payments for your ASC. But I would hold off thinking about entering in any sort of preferred network or recognized site program at this time. Great.
Thank you, Dr. Malo, for your insight on that question. The next question is, hospitals and payers appear to be under fire lately over surprise billing by consumers and patient advocate groups. Is there anything we can do to better this situation for our patients?
That's another wonderful question. And I'm going to say, as a future patient in a couple of weeks, I've been dealing with this quite a bit in my own particular situation. While my ASC and my physician have been upfront with the budgetary estimate of the procedure, the one thing that I've been having trouble with is the anesthesiologist, which is a separate group, who has been very difficult to communicate with and pin down any sort of number on how much they may charge for my particular case. And it's these types of issues, especially when a provider is considered out of network, that really generate those surprise billing problems. And we've seen recent laws out of California, New Jersey, and New York trying to prevent these cases. Unfortunately, when the legislatures get in, they're usually bringing a hammer to the party and making it very difficult in unintended ways. So you, as the ASC provider, I would encourage you greatly to think about how can you provide reliable and valid information over the entire cost of care of that case at the time of initial scheduling of the procedure, not 2 weeks before, not a week before, but at the time of the initial scheduling. And that means working with the other specialists and other physicians who may be in your ASC through a central person or conduit to provide that information in a holistic manner.
Great. Thank you again, Dr. Malo. That concludes today's webinar. We want to thank again Dr. Malo for his insights and Cardinal Health for sponsoring today's program. We hope to have you join us for future webinars.